Okay, thanks everyone for coming to the CHEP seminar. Of course, doing great. We have Adam Shumway joining us today. Adam's a PhD candidate in economics from Cornell University. He's a labor economist with interests in occupational licensing and economic history. He published some of his work in the Journal of Family and Economic Issues with our friend Joe Price. And today he's going to talk to us about some historical data he has on doctors' location choices and medical school access. Thanks so much for coming.
Thanks for having me. Please interrupt with any questions. I think I'm running a little on the short side, so plenty of time to talk if you want to bring anything up. Yeah, I'm going to talk about where doctors work, medical school access, and the rural physician shortage. I'm an applied micro person. I'm interested in academic and government positions. And like Joe said, my interests are regulation, historical data, and wages as well. So I will first motivate my research question from a couple of different angles, and then give a little bit of historical background, mostly to help you understand where the identifying variation is coming from for this project. I will then discuss what I'm contributing specifically with my research. The fourth section will be the data work, which is a large portion of my contribution, so I'll spend quite a bit of time there. The analysis in this project, as of yet, is fairly simple, and I will then go on to the analysis and conclusion. So let me start by motivating this from the side of why we might think medical schools would affect doctors' practice locations. So how might the geography of medical schools in the United States spill over into the distribution of doctors, if it does, and why might we think that would be the case? One thing to think about is that schools may provide positive externalities. So they have research facilities, clinics, associations with hospitals, things that may be amenities to practicing doctors. There's a medical community and associations in an area around a medical school. Second way that we might think medical schools would affect doctors' practice locations is through school characteristics influencing doctors' preferences or decisions to practice in rural or urban areas. So one way to think about this is looking at in-state retention rates. This is actually for residencies. So students who do a residency in California, 78% of those students go on to practice in California, whereas the retention rate is quite low in other states like Wyoming. And finally, as I mentioned, students who study in small towns may develop a preference for living in that type of area. So those are a couple of reasons why we might expect medical schools to be important.
Sorry, are there, and this is my lack of knowledge, both historically and even currently, about whether medical schools have any tuition breaks associated with the residents of the
I believe so. Anyone that knows more, feel free to speak up. I think that I'm going to mention this later, but I know that, for example, the University of Utah has to reserve 10 seats every year for students from Idaho, which didn't historically have a medical school until just recently. So I expect that there would be some differences in tuition costs based on state versus out-state tuition, just like with public schools.
Yeah, I mean, so I should know this. My brother went to State University of New York. Yeah, at Stony Brook on Long Island, and I don't know whether there was a specific tuition break that resulted from him being able to claim an in-state residence or not. I know. I mean, other graduate programs, I know that's certainly the case. I just was unclear whether medical school was money.
Yeah.
It does appear that the UC medical schools have out-of-state tuition.
Did you say it is true?
Yes.
Okay,
Yeah.
perfect. So then it is. Yep. Thank you.
I have a comment.
Yeah.
Do we think that this is different for other types of schools? So what separates medical schools and the impact of geography on that relative to other professions? Is there something unique about the medical profession that results in people living near those schools, or is
Yeah,
it more or less?
that's a really good question. I actually want to, another research project that I want to work on is looking at college towns and how they've affected the geography of the United States. So that would be kind of in a similar vein. So yeah, what I can say about that is that because we may expect there to be fewer ties in some ways, because doctors are universally in demand across the United States. Healthcare is a good that everyone needs. And so in that respect, we might expect people to be able to practice anywhere once they become a physician. And certainly my later point here about students developing a preference from the location where they attend school, that would hold as well for their undergraduate degree or even maybe high school or going back to earlier years. So in that sense, I don't think there is any difference for that. I guess if this first point is an important one, that there are research communities or things like that that very many doctors have an interest in, that could be a point of difference. But my gut instinct would be to say not too much of a difference between the strength of ties between medical schools and other specialty schools. Yeah.
Well, like to your first point, I don't know how common it is for physicians to start out or come back to kind of a hospital that's connected with the university, but a lot of medical schools kind of do have affiliated hospital systems.
They certainly do. Yeah. Yeah. So if that is common, then that would be a stronger type. Yes, exactly.
Just so one thing that may help with Jake's question is that each state have their own medical license. And if you move from one state to another, you have to reapply for the license.
Yeah.
That takes a long time.
It's not crossless to across states. And many physicians have licenses at the same time for multiple states as well. They'll practice in multiple states or be able to practice in multiple states.
Yeah, this got me thinking about sort of the differences between medical school and law school, where you have to pass the board sort of in a given state. Which is the reason why, I guess I'm trying to sort of understand, I don't know if that's what Jake was trying to get at, kind of fundamentally why you chose to sort of look at medical schools instead of like law
Okay.
schools. Is it because of the policy experiment that you're able to exploit? Is that it?
Yeah, exactly.
Okay.
So I promised Shoshana that I would talk a little bit about how I got to this project. It's a bit of a long and winding road, but essentially I got the data at first, and then I was trying to figure out cool things to do with it. And so this is what I ended up with. I was planning to go more labor market outcomes initially. I haven't done that yet, but because I wasn't able to get wage data for anything other than the census 1940. So this was very much a data-driven project in terms of what I had and what I could look at. To make a long story short. Any other questions or comments on this? So let me motivate it now from a different angle, thinking about why we might care about the geographic distribution of physicians in the first place. So these are projections, sorry, they're a little bit small, from the American Association of Medical Colleges about shortages in future years. So in 2019, there were about 14,000, according to their numbers, if you believe their methodology, about 14,000 primary care physicians shortage. And some survey data on that is that 35% of people know someone who had trouble finding a doctor in 2019 as compared to 25% for that same statistic in 2015. And then this paper by Jang et al. Uses a similar methodology, looking at population and predicting demand for healthcare based on that. And the number of states who are doing poorly in their metric is increasing from 4 to 23 in coming years. And to add on to that, there's quite a divide between rural and urban areas. So physicians historically and today live disproportionately in urban areas. Part of that is demand for certain specialized services would only be sufficient in urban areas for, you can imagine plastic surgeons probably aren't in super high demand in really small towns. And then the variance at the state level, you can see here, is from about 200 doctors per 100,000 population in Wyoming going up to 435 in Massachusetts, so, yes.
Now, that physicians urbanize disproportionately, I would see that as a supply side effect, because there's more of a supply of physicians to the urban centers, right?
Yes,
And that reminds me of an article, I think it was published in the JP years ago, about power couples. And that because of the, comparing, let's say, to 30, 40 years ago, there's a higher percentage of female graduate students. And then there's more marriages that are formed in graduate school or medical school. And then you have more power couples looking for two jobs in the same location. And that makes it more difficult to settle in a rural area. And I believe one of the authors of this article about power couples is Dora Costa.
okay. Yeah,
Dora Costa.
yep, that could certainly be a part of this. We've got several couples like that, and I know I can, so, yeah.
I have to admit, I don't have many details, but I feel like more recently, there's been a lot of financial incentives to get physicians to locate in rural areas because of exactly
Yeah.
that problem. So I'm curious kind of how, if you are aware, like how that might be changing distribution.
Yeah, so I think that certainly has had, there are some papers on that, and it has been effective to some degree. So I know in 2003, there was some policy for Medicare that set standard prices across the board that was essentially incentivizing physicians to go to rural areas. Yeah, there has been efforts from the government side to alleviate this shortage as well. And this is a picture of access to COVID care in April 2020. So the shaded areas are more than half hour drive to access that would be appropriate for care to COVID. You can see the stark divide kind of east and west of the Mississippi. So a lot of this is, of course, where the population is as well. But again, giving you a sense that there are inequities across the country. So my research question is, how does the geographic distribution of schools spill over into the distribution of doctors? Now let me give you a little bit of the background on the variation in schools that's happened over the last century. So America was a bit behind Europe when it came to medical education, especially in the early 1900s. European schools at the time were using scientifically based instruction and clinical laboratories, and there was a strong association between research and instruction, whereas American schools were there were a few good schools here. Johns Hopkins has always been kind of a shining star, but by and large, there were a lot of small schools that took advantage of kind of poor students. There were a lot of advertisements for come to medical school, it's a great career, and just very shoddy education, and some fraudulent schools as well in the mix. And so around this time period, some reforms were happening at the state level, and kind of the big one that people point to was this report that was published by Abraham Flexner in 1910. He was not a physician himself, he was an educator, but he was hired by the AMA, Council on Medical Education, to visit all 155 medical schools in the US. And so he took about 3 years doing that, and gave every school a letter grade and said, this is what they have, what they don't have. He asked to see a laboratory at one school, and they went upstairs and brought the microscope back down, and that was their whole laboratory. So there were some horror stories that he put in there. And his recommendations were that there be sweeping closures and mergers of schools across the country, essentially that the standards needed to go up. And the easiest way to do that was by closing everyone who didn't have any hope of meeting those standards. And by and large, his recommendations were adopted. I'll show you on the next slide what that looked like. So that was the early part of my period. My data start in 1909.
So we're sort of existing, was also part of the recommendation to expand existing schools or to reduce the number of slots or what?
So, yeah, existing schools expanded, especially if they merged with other schools, student populations and teachers. I think that they didn't feel like there was a projected shortage or anything at the time, and they may have thought there were too many people being educated to become doctors with all the small schools in the Midwest that were super low quality. Most of the schools that did survive did have to up their standards by a significant amount, and so they were reforming as well. From the report, there was certainly an effect on those schools also.
So prior to the, sorry, I just want to understand it. So prior to the issuance of this report, how was it that medical schools were established?
So a couple doctors could go off on their own and start school, in a lot of states. Yeah. There were lots of reforms happening around the same time period, so states were cracking down harder as well, and the AMA essentially became the certifier of schools going forward. And so so those standards changed pretty quickly too around this time period, but prior to late 1890s or 1880s, it was certainly still a case that lots of people could just go start school and even be practicing in a small town and just teach on the side, 9 classes or something to make some extra money.
When does the AMA start relative to this report?
So the AMA started in, I want to say 1847, but it didn't have much bite through all the first 50 years. So 1905 was when there was a big meeting of the AMA that kind of, it first started to have some power, and states were finally accepting what the AMA was telling them they should do. Yeah. So the early period of my data, we'll see a lot of closures. 1909 is my first data point, and so that's right when this report came out. And then government reports have largely been the drivers of the openings and closures of medical schools going forward. So in this 1959 report, the Physicians for a Growing America predicted a bunch of shortages in the upcoming 10 or 15 years. And you'll see that from 1960 to 1980, a bunch of new schools were built, kind of directly in line with that. And then in 1980, there was a prediction of a surplus by 1990. And so that's when no more schools were built. And just for your own information, we are now in another building phase. Since about 2010, there have been 27 new schools open. And so there are a lot of new schools being built right now. And some reason I would argue for state policymakers or the people who decide where to build those schools to think about the research going to do there.
So again, so so the reports come together, the AMA makes recommendations to sort of state policymakers, and they seem to go along with whatever the recommendations of these reports as they come out in terms of how many new medical schools they're going to license. Is that how?
So the AMA is the one who's certifying medical schools now. So yeah, if the AMA isn't on board with a medical school, it's very hard to get licensed, and it's a long process. It's like 8 to 10 years.
And what's the legislative process have to look like? What do they have to sort of sign on to?
So that's a great question. I don't know too much about it. I do have a report. I've read a Texas report on like the costs of it, which doesn't go much into the legislation, but I think there has to be an association with the hospital. There has to be sufficient residencies for any students that will be. So the opening of new residencies is a very important thing that happens when medical schools are opened as well. Because that's kind of the binding constraint on doctors joining the US, not actually the number of medical schools.
I feel like a 5-year-old on Christmas morning. I don't understand why I'm shocked that the AMA is sort of power to sort of decide when we're going to have new schools or shut them down. That's.
I may be overselling it a little bit. Yeah, I mean,
I don't think so.
you can see what the data.
Sounds, I mean.
Right, they determine precisely how many doctors will be trained in a given year and see that there's a match for them in a residency, right? They control that whole process.
Are you gonna get to any of the Milton Friedman ideas about the AMA? Is that gonna be related?
Oh, That was some of the inspiration for the project in the first place, but I don't have any of the, nothing related to that here, unfortunately, so. Yeah, so let me show you, you can decide for yourself. So you can see that the number of schools was already closing prior to the publication of the report. So there were other reforms going on at the time, like I said. And then with the Bain report, we see an increase in schools for about 2 decades, and then again a flattening out over the next time period. So now let me talk a little bit about what's kind of relevant to what I've done here, and then talk about how I'm adding on to it. So this paper by Moeling et al. Uses also the American Medical Directories, which is the data set that I use. And they use early directories from just up through 1927. So the first directory was published in 1906, and they're published about every 2 or 3 years. You can think of them kind of like a phone book for doctors. They don't actually have the phone number, but they're essentially a listing of all the registered doctors in the US. So this paper looks at how the Flexner reforms specifically changed the urban-rural distribution of physicians, and they find that over this 2-decade period when all these schools closed, that the likelihood of physicians practicing in a rural area went down by 40%. So quite a large effect. They do some neat stuff like matching to ancestry records to control for the birthplace of the doctors to account for that as well. So their version of the data is all hand entered by RAs. And so they do it with a limited sample of states, I think 10 states for some analysis and then 4 for some other analysis. Whereas mine is all digitized, and so mine has lots of errors, but has the whole United States in my data set. This Blumenthal paper is essentially a review of the last slide. So it talked about how the role that the AMA has played in the building of new medical schools and the closure of medical schools over the last century, and kind of arguing that those reports have been super influential in medical school construction. And then finally, this Beck paper talks about some of the unintended consequences of the Flexner report, like a disproportionate reduction in the number of doctors serving disadvantaged areas, and also there was the closure of some historically black colleges and medical schools as well, that some might see as kind of a setback. So what do? I'm constructing a novel data set for the study of the physician labor market, and that is a large part of the contribution, at least in the current version of the paper. So the data set has broad time variation. It's linkable to other sources because I have the names of all the physicians, and there are multiple variables of interest that you might think about in relation to the data. So physicians' migration patterns through time, their education, their specialties, etc. So I'll go into a lot of depth about how I built the data set and some of the difficulties associated with that. I'm studying what Moeling et al. Studied over a broader time period and with richer variation. And I do find that schools have an influence on where doctors end up. And so I'm kind of reinforcing the idea that they're finding in that way. And I find that this is true even when I just look at post-Flexner variation as well. So importantly, I'm looking at, even if we just look at the openings of medical schools, I still find that there are effects. And then finally, I'm using a multi-pronged approach to the research question where I'm looking at some individual level analysis as well as a broad county level difference in differences. So let me give you a quick preview of the results. I find that the geography of medical schools does matter, and small town medical schools are associated with more doctors practicing rurally. There aren't really any schools in super small towns. I think the smallest is like 11,000 or something like that. So there aren't schools in any tiny towns, but doctors who go to schools with less population in that county will be more likely to practice in rural areas. And then I also find from the difference in difference analysis that there seems to be an aura effect in terms of schools, counties that are near medical schools have more doctors than counties that are far away from medical schools.
So maybe I'm missing something here, but it seems that this is just kind of consistent with the story that certain people have preferences for small towns and certain people have preferences for large towns, and maybe on some margin that if there are medical schools in the small towns, and I like to go to small towns, I'll go to medical school, and if I have to go to the big city, go to medical school, maybe I won't. Is this kind of the proposed mechanism that you're thinking about, or is there something kind of more?
Yeah, so I'd like there to be more than just that. So I do control for the birthplace, which you may or may not think is doing something to account for those preferences. And there is still an effect beyond that.
Okay.
But you're certainly right that there's selection into smaller town medical schools, and that would be correlated with this innate preference for practicing in a rural area.
So the exogenous variation here is coming from the closure of medical schools from the report that were potentially disproportionately in rural areas, or are they relatively balanced?
So that's a great question. I did have a map on an old version of these slides. So for the closures, a lot of the closures were in cities with multiple schools. So a lot of cities with 6 schools would go down to 2 or 1, which is not changing the geographic, my variable at all, which is distance from the nearest school. There were some in the Midwest and kind of smaller towns that were, that would be the main source of my closure variation.
Okay. And then so from the diff and diff, it strikes me as kind of a non-standard diff and diff, because it's like SUTVA violations will be rampant here, right? Where because you're looking at labor supply and labor demand.
Yeah.
That places that even don't see any change in medical school closures, their labor markets are presumably affected by the changes in others.
Yes.
Right.
Yeah.
Okay. So yeah, and okay. Do you have a way to think about how to translate the coefficients that you'll get from this exogenous variation into what they might mean in terms of general equilibrium?
That was a great question. I don't know too much about how to do that. Yeah, I thought about it a little bit, but yeah, I don't have something right now. That's definitely something I should. That'd be a useful number to think about. I agree for the final version of the paper. Yeah, so the analysis is still kind of at a preliminary, simple stage. It should be way beyond that with how long I put into the project, but yeah, not too much in-depth analysis at this point. All right, so let me talk about the data work that I did. So these are the years of the directories that I use. I've actually added on all the missing decades. I have those, but not incorporated into the paper yet. I'm in the process of tweaking them at the moment. So you can see that there's a directories corresponding roughly to the decades. So 1909 going along with 1910, 1921, and then 1936 is for 1940. So closest I was able to get to that year. And then there's a skip of 2 decades up to 1970, and then a skip of 1 decade to 1990, and then to 2011. So I do now have each decade covered, but not in today's presentation. And then, like I said, it's like a phone book. So I have the location that the doctor lives, and I have address for those who are willing to give it, their school information, including their graduation years, so I can approximate their age. And I also see the year that they were licensed in the state that they're in. And I could see society membership and then their specialties. I have full count census data for 1940 and before. And so I'm able to link on names for using that data. And I have census data also for the publicly available samples for the decades after. And then finally, I constructed a panel of medical school openings and closures, as well as their locations. So this is a picture of one of the early directories, I think 1927. You can see a couple of characteristics of it right off the bat. So I apologize, it's also a little small, but on the top line here, I have Auburn, Michigan, and then Battle Creek. So I can see the cities that this page spans, and then at the top left, the entry for Auburn says Auburn 300 Bay. So 300 is the population of Auburn, and then Bay is the county. And so there's only one doctor in Auburn in 1927. One difficulty that you can see here, if you look at the entry for McNabb. So he was educated in Illinois 1, which is the first school in Illinois. You can see that the capital I, the lowercase l, and the 1 all look, pretty much like a vertical line. And so the optical character recognition program that I use has a lot of trouble with that, and I have to work around that. The other thing you'll notice is that for any city, there's only one line that identifies it. So these are all pretty small cities here, but New York City is going to have one line that says New York City, and then it's going to have all the doctors practicing in New York City. And if I fail to read in that line, there's going to be a big ramifications. Lots of doctors will be wrongly attributed to be practicing in whatever city comes before New York. So it's really important to correctly identify which lines identify cities in the data. It's not such a big deal if I can't, if I miss 1 or 2 doctors. So yeah, the first challenge is getting the location right. And I worked on this for quite a while. With the column formatting, it's very costly to misread one. And so there are some characteristics you might think of. For example, I see commas and I see some text, and then I see numbers, and then I see text again, and any city line because it has the city name and then the population and then the county name. And so that's a pattern that I tried to exploit at first, and it works fairly well. The OCR also has difficulty reading in all of the periods and commas correctly, and so it's sometimes hard for me to use just patterns like that to identify all the city lines. Ultimately, I realized that I could kind of work backwards. So I have a list of all the cities in the US, and I know what counties they're in, and I can match streams using that list within each state, and so that's what I ended up doing. And I think it was, for the most part, successful. One thing that you want to start from that side, since if I don't read in, for example, the B in bad acts, then it's going to look like it starts with an A instead, and so it's hard for me to sort by city with my error-filled data and expect to match well to the cities in the actual data. But starting from the other side, I can have bad acts and look for any string of 6 characters that roughly matches that. That's how I ended up matching cities and counties. Another very difficult part of this project was identifying when each entry is a new position. So the little tabs that you see here don't show up in the OCR. The little tabs for overflowing lines. And so essentially I did have to use patterns here. Look at text. So you see some of the doctor names are in all caps. Those are members of the AMA. And the ones that are in lowercase are ones who are not. But essentially I use patterns like text followed by a comma or a period. And then one big thing in these early data sets is this born clause. So this doctor was born in 1896, and every time I see a new lowercase b followed by a character followed by 2 numbers, I know that that's a new line because it's the birth clause for that doctor. And then I already mentioned the similarity of characters like you see here. Yeah.
So do you have a way of validating your matching process? Can you use the census data, for example, to match geographic locations with the names and things like that?
Yeah, I have. So I should do that because I can totally do that. I do, none of my years match up exactly, so there would be some expected errors there. But I should totally do that, because that's something super fast and easy to do. But I do match to the paper that I mentioned earlier. They shared some of their data with me, and I'll show you how well I match up to their Canada Intern data. So I can show you that. So here are some summary statistics. AMD is the American Medical Directory. So you can see the total number of doctors that the AMD identifies. So I get this from the front introduction page of the medical directory. It says, this is how many doctors are in the total US this year. And so that's kind of my goal that I'm aiming for. You can see in the second line how many I actually identify. And then the third line is the number that has valid medical education information. So I see where they went to medical school and it matches something that I would expect or that makes sense to me. One important thing to note there is that I'm throwing out any internationally trained doctors, which I think plays a bigger role in the later years of data. So you'll see 2011 is kind of a special case in terms of I'm missing out on a lot of observations there. Part of that was the scanning process was different from other years. So I ended up using, I had cut the papers from their binding and scanned them through a scanner. There's only one scanner that would work. And so that may explain why there are kind of more errors in that data. And I think the omission of internationally trained doctors plays a bigger role in 2011 as well.
So just to be clear about the doctors sort of listed on the top of the journal and the ones you sort of identify, is that due to the names not being provided or your inability to read them from the directory? Is that how many names are in the directory?
Yeah, so that many names should be in the directory, and the ones that I missed out, I just didn't identify that they were a new observation. Yeah. And a couple of the directories, I think I'm missing 1 or 2 pages. So so on the fourth line here, you see the specialty, and you can see that specialty was not very commonly reported until after about 1940, when we had a huge spike in that number to report a specialty in 1970. And then I'm just throwing this on here kind of as a very rough check of data accuracy. It's a number that I could easily produce, and that is a correlation between doctor population and the total population at the county level. And so you can see, how far off that is in various years, which has to do with how accurate I'm identifying the location. These are some statistics from the census data, and give you a sense of trends in the number of doctors in the US. And so going from 1910, there were actually more doctors than later years, 1920, 1930. I would love to study if doctors actually changed careers with the reforms at this time. Doctors who have not been trained very well switched into other occupations. That's something I haven't looked at yet. And then you can see the share of female, the share of Black, both been steadily increasing. And you can see that the population has been catching up in terms of the share of urban. We're about 80% urban in the United States. The doctor share of urban was a lot higher relative to the population share, which is going to the census definition, which is a place of 2,500 people or more. And then finally, here's a table where I can compare the number and age of doctors by year and data source. Again, I'm just throwing age up here kind of as a rough check to make sure that the data are, roughly in line with what we'd expect, not an important outcome variable otherwise. And the interesting thing you can see here is that depending on the year, one or the other data source reported quite a large number, a very different number of doctors from the other. So in 1910, the census was reporting about 20,000 more doctors than the AMD was. And then in 1920, the AMD was reporting about 30,000 more than the census was. And some of this may be that doctors had, initially signed up in the AMD and then weren't practicing later on in their lives, things like that. And then again, in 1940, you can see that there are many more in the census than there are in the AMD. So there's just quite a bit of variation even in those two sources that we might expect to be more similar to each other. Again, on the right is the number that I've captured with the digitization process. So this is, I guess, has a leak, but this is what I was promising to show about the accuracy of the data. So this is from Gregory Nemish, very graciously sharing some of their data from their paper with me. And so this is just a subset of my data since they're only using 11 states. And so I'm only looking at the accuracy for the states that they have, of course. And you can see that the important variable that I'm going to be using here, which is this county variable, I have about 70% accuracy in both years that I'm comparing here. And you can see that the numeric variables I'm not always capturing. So I don't claim that there is a licensure year in all the observations, for example, but when I do capture them, they are within 10% or so of being accurate. So the OCR process does a good job with numbers. And then in 1927, you can see that the accuracy numbers improved for the numeric variables. For the county, it was pretty similar to what it was in 1909. So that gives you a sense of the accuracy of the data. And I'll just be using the county for what I do today. So the city variable isn't too important. So let me give you an overview of the analysis that I'll do. The first analysis looks at an individual level. So I use a pooled cross-section where I'm looking at doctors from 1970 and 1990 and matching them on their names to people in the census 50 years earlier. So I'm matching the 1990 American Medical Directory to the 1940 census, and then I'm matching the 1920 census to the 1970 directory records. And that allows me to see where the individual is living between the age of 0 and 10. So it's going to give me something like a control for birthplace. And so that pooled cross-section, again, I don't have any controls for things like innate preference for rural areas. And so it's not a causal regression, think of it more as something descriptive, but it will, I'll show you the results from that. And then I do a county level difference in difference where I'm looking at the number of doctors in a county relative to how far that county is from the nearest medical school. And that's the second branch of the analysis. So here's the model for the first section. I'm looking at whether a doctor ends up in a rural location based on the location of their residence between ages 0 and 10 in the census data, which is the rural residence variable. And then the school characteristic that I'll look at is the population of their county in the decade that they attended medical school. So think of it as some doctors are going to kind of smaller town schools and some doctors are going to bigger schools. And then I include a vector of specialties as well to account for different demand for specialties by location. And again, I do this for 2 cohorts of doctors. I use a very strict matching process, so the sample is fairly small. I just matched on name essentially, and I use only males to ensure that the name is correct. That's why I'm changing the last name. So let me show you the results. First, this triangular table. So if I only include the log school county population, you can see that there is a negative relationship. Doctors who go to bigger town schools or big city schools are less likely to end up in a rural area. The definition that I'm using for a rural area here is a county with a population of less than 20,000. And so I'm defining rural differently than the census, which does it at the city level. I'm using the county level for the definition of the variable here. And I'm going to vary that definition over the next couple of slides. Here is a county with less than 20,000 people. You can see that when I include the rural residents between the age of 0 and 10, so like a birthplace control, that has the sign we would expect. People who go to our rural areas are more likely to end up in rural areas. And then the coefficient doesn't attenuate very much on the school characteristics. And that holds also for this last specification where I include the whole vector of specialties. I only show family practice here, but I do include all the specialties given, as well as age, and then I have a control for the 1970 standard for that. So here are a couple more versions of this regression where I let the outcome variable change. And there are a very small number of counties with less than 10,000 people. And so the number of doctors who are actually practicing in these counties are small. And that may explain why the coefficient rises or becomes larger in magnitude as we go across the specifications here. It's just a very small population that actually has a positive outcome variable when we look at counties with less than 10,000 people. And again, you can see broadly that there is an effect of school county populations getting stronger depending on how strictly or loosely we define the outcome variable. And finally, here's an alternative way of thinking about it, where I'm considering any location with a certain number of doctors to be a rural location. So I can add up the total number of doctors in each county and say, what if a county has less than 5 or less than 10 or less than 20 doctors? How does that look? And it's again, the same type of relationship here. So a little discussion on this. As I said earlier, it's not interpreted causally. Preferences for rural areas is something that I don't see, and it certainly would affect choice of medical school as well as choice of practice location. Individuals who prefer rural work may sort into the more rural schools. And I was speaking with the chair, I don't know how to say his name. Isham. I was speaking with Isham earlier, and he brought up residencies, which is a very important link. As you can see from the retention statistics at the state level, and I don't have data on the residency. Was asking him if there would be a way to get that, so that would certainly add a lot of interest to this. And then, as I mentioned earlier, schools have different admissions criteria as well. So from the school side, there are certain things that have to be met. For example, the University of Utah reserving seats for Idaho students, and those students may be more likely to end up in rural areas as well. Let me show you the results or the model for my difference in difference. So I'm looking at the number of doctors in a county, and the main control is the county population to control for demand for medical care. And then the regressor of interest is the distance from the nearest medical school. So log distance in miles from the county center, the population weighted center to the nearest medical school. And I include county fixed effects to allow for inherent characteristics of counties that may make them more or less appealing to doctors, as well as year fixed effects to account for time trends in the overall supply of doctors. And again, these are the decades I currently have, will be all decades eventually. So these are the results from this analysis. So the first column is just using all counties, and then I do a couple alternatives on that. But you can see that in accordance with what you might expect, the log county population is positively associated, and it's a little bit over 1, which is kind of in line with what we know that doctors have been practicing more in cities proportionate to the population. And so that goes right along with that. And then the log distance to the nearest medical school does have a modest effect on the number of doctors in a county. And that effect seems to hold when I just look at the contiguous United States. which I was corrected. I used to say continental United States, but Alaska is part of continental, so it's the contiguous United States. And when I just look at the post-reform era as well, so this third column is one of the big contributions in terms of adding on to Nolan's work. That I see even after the reform era, post-1940, that the effects are fairly similar. So some caveats with this: the identified effect does include anything that comes with the opening of a new medical school. So it's a bundle of events, which includes additional residencies, expansion or creation of hospitals, everything that goes along with that. Of course, doctors work at hospitals, and I meant to say doctors work at medical schools, and so there's a small effect from that as well. Population control is an imperfect demand for healthcare. There are types of healthcare that are more in demand, higher incomes. Not all healthcare is a necessity, of course. And then finally, scope of time variation, I would point out as kind of one of the big contributions of this project is that I'm looking at both closures and openings. There is, I only have what the data have, which is closures in a certain time period and then openings in the other from 1960 to 1980. And so it's not super random in the sense that I see schools opening and closing at random kind of throughout the sample. But I do cover the entire variation of it.
But it largely suggested, right, from those results that the effects were symmetric, even though there's sort of very different areas and happening for potentially very different.
Yes, it is. Yeah.
I want to see more about what Ryan was saying, kind of the general effects of just there being fewer slots versus like changes in the distribution. I don't think I have perfect solution, but I was just trying to think about like, do you think there are a lot of people in your data set that are just like people who are going to stay in their home state no matter what? Like they're born in California, they're going to go to school wherever they can get in California, not just in California. Because I'm just wondering if you can kind of compare states where they lost slots, they lost medical schools, but maybe the distribution in California, rural versus urban, kind of stayed the same, but the distribution in another state changed a lot. So they both lost slots, but they like the distribution effects were a lot different. And like you can kind of focus on people who tended to stay in their state, which obviously is equivalent. It is kind of a different sample, but just to kind of provide some suggested evidence on the effects of like losing slots versus.
Yeah, I could. It might be more compelling to do like gaining slots with the openings of new schools with that type of analysis. That's a really interesting idea. To kind of link the people who go to school and stay in the state afterwards.
Right, but I just like to sample, but just kind of as like a suggestive.
Yeah, I love that. Thank you. So that about wraps up. So again, I find that both from my pooled cross section and my difference in difference, school location does appear to matter. I won't make sweeping claims about how causal this is, but again, I think there is some indication for policymakers to be aware of this thing. And since we are building new schools currently and schools are being built, I think there's some consideration to take into account where that we can place them strategically, essentially, to help alleviate the rural physician shortage. And again, I find that the effect is fairly symmetric when we look at pre-reform or the reform era and the post-reform era as well. I can talk a little bit about my future projects. So with this data set, I am hopeful to estimate returns to education and specialty using property values from recent directories, maybe just the 2011 and the 1999, linking doctors to the locations where they practice. And then I'd also like to overlay at some point the physician assistant and the nurse practitioner distributions, because those occupations have become very prevalent. And I would be very interested to see how those have interacted with doctor shortages in rural areas as well. And so that's another project that I hope to get to.
How has this situation being perceived and has affected politics? Are there any local politicians who present this as an issue for voters? Because if I were to live in a rural county with a real undersupply of doctors and knowing that this increasing information that this affects mortality, I would be very upset. I would want to have more doctors where I live. And since there is a clear connection between how many hospitals and medical schools are built in different parts of the country, and given the AMA control over these decisions, I would imagine that politicians have a lot to say about it and that voters would wanna make this an issue, is it?
I haven't seen a lot. I think there has been some debate at the national level about number of residency slots, number of schools in the US, and how much control the AMA should have over those things. So I think there has been some debate at that level. I know that there's a very strong lobby for the medical profession in Washington, DC. So there are certainly some powerful organizations involved, but I haven't seen any local news articles or rural area type articles. I haven't looked that much, so they may be out there, and I just haven't seen them. But I agree, it does seem.
But given that you do research about this, you would have noted some news that I might not pay attention to.
Right, yeah.
But you haven't seen that.
I haven't seen much, no. Yes.
So you said you don't have data on wages, but what would you think that would be? I mean, what would or how would these closures affect the urban-rural wage gap between doctors? And I think that would help kind of clarify some of the general equilibrium effects that are going on here, because if it's, there's a huge shortage and, I'm gonna live in an urban area now because the wages have gone relatively higher just because there's less doctors. I think kind of knowing that would, even if it's just a prediction where you don't have the data to confirm it, I think that would be helpful.
Yeah, so I do have wages from 1940, so I could use that. I agree. Yeah, I have the census variables from before that, so I do have some things like home ownership and things like that. I don't know how useful those would be, but yeah, I would love to find something early that I could use as a proxy for wages, because I feel like that is certainly a big part of it. Yeah, I agree. If there was a constraint in supply over the nation overall, I think there would be more solutions to cities naturally.
Has there been work, or I've missed it, sort of on the health and mortality effects of the closures, especially earlier in the century after the Flexner report sort of came out, about sort of thinking about what it's going to mean for, the goal, right, is to change the distribution of medical schools to have on average higher quality schools, but maybe further away, particularly in some kind of rural areas on net. What's better, going to a close worse, having access to worse, well, according to yourselves, right, worse doctors trained there, and you think that they're going, the doctors trained there are gonna end up worse, you have a closer, worse doctor, or traveling further to a better doctor, what do we know? Do we know anything?
I don't think there's much literature on this. This was also a time period when other things that had a really big effect on health outcomes were happening, like sanitation systems in cities. So I think the best bet for doing that type of analysis would be to overlay it on a similar paper that is maybe looking at sanitation in cities or something like that. Yeah, I think I mentioned to you earlier today that I did do a bit of work with childbirth related mortalities, which was one of the biggest causes of death in the early 1900s. And I found just from that I didn't find any differences in like overall level of education when I was ranking the doctors based on if they went to a good school or bad school. So I didn't see anything like that. most counties in my data did have like multiple doctors from good schools and bad schools in the same county. And so it's kind of, I don't have, of course, like where the mom was, you know, who the mom's doctor was when she was giving birth. I don't have that data. But yeah, the main takeaway from that analysis that I did was that the number of nurses was more important than the number of doctors in those early years, as far as childbirth related mortality improvements. Yes.
What is the role of the US military here as an organization that trains doctors and has changed over time?
So that is a great question. I omitted the military from my scanning. I don't have the data. I could add it on because the directories do list who is serving in the Army and the different organizations. So it certainly plays a role. I don't know if it's a big role, but yeah, it's certainly something I could look into. Did you have any thoughts about something that might be interesting with that data, or just wondering? Yeah. Yeah, I don't know if they've, it'd be good for me to at least know the number of doctors that they've been training. And whether
Would I
that's
be able to find somebody who works on, you know, at West Point or what, an economist who's connected to the Defense Department and then maybe doing work on this, and you might be able to team up with them and do something.
Yeah. Thank you.
Any other questions? Thank you. You all have a wonderful spring break. Our next speaker will be Steve Trejo visiting us from UT Austin on April 7th. So we'll see you back then. Have a great spring break.